Recording in progress.
I'm Bruno Cano, Training Manager, Professional Education for Olympus Europa.
Here's our disclaimer. This presentation is for your general knowledge and background only. The procedures and techniques described in the course should be performed only by a trained physician or medical personnel under the supervision of a trained physician. Olympus makes no representations, warranties, or other expressed or implied warranties or guarantees regarding the accuracy, reliability, or completeness of the information. Proper attribution should be provided for any use of the information contained in this presentation. Under no circumstance shall Olympus or its employees, consultants, agents, or representatives be liable for any costs, whether direct, indirect, special, incidental, consequential, or otherwise, that may arise from or be incurred in connection with the information provided or any use thereof to the maximum extent permitted by applicable law. Disclosure. The physicians presenters are paid consultants to Olympus Europa SE CO KG. This educational course provides information on the JNET classification system. While the JNET classification may support clinical decision-making, it is the sole responsibility of each healthcare professional to determine the appropriate classification system to use in their practice. All interpretation, application, and diagnostic conclusions derived from any classification system must be by qualified medical professionals, in accordance with their clinical expertise, institutional protocols, and applicable medical guidelines. The Olympus products within the program may not be available in all regions. As with any medical devices, careful consideration should be given to all applicable labeling, including potential risks and benefits associated with the products. The availability of the products in each country depends on approval by the applicable health authority in each country, and they may not be available for sale in your market.
So for your general knowledge, this session will be recorded. Microphones and camera are automatically turned off. Please use the question and answer function to ask your questions. Please be aware that during the session, maybe your question could not be answered at the time. So we kindly ask you to wait for the answer, and we will provide to all of you, if we not have enough time to answer your questions, you will receive an email from our side after the event. During the session, please select your answer using the voting function during the clinical cases and discussion session. After the session, please take a moment to fill out our poll survey after the seminar. This will take less than 5 minutes for completeness. So now I have the pleasure to announce our faculties for today. Our first faculty will be Professor Shinji Tanaka, President of Japan Gastroenterological Endoscopy Society and professor at the Department of Gastroenterology at GA and Onomochi General Hospital in Hiroshima, Japan. Professor Yasushi Sano, Clinical Professor and Director at Gastrointestinal Center Sano's Hospital in Kobe, Japan. Professor Takahisa Matsuda, Director of Gastroenterology and Hepatology Center, Internal Medicine at Toho University Omori Medical Center. Our European faculties, Professor Alane Bigbo, Clinical Director and Head of Department Internal Medicine, Gastroenterology and Interventional Endoscopy, St. Joseph University Hospital in Bochum, Germany, and Dr. Serhiy Polishuk, Head of Gastroenterology and Interventional Endoscopy Department at Gastro Center, Olimed, in Kiev, Ukraine. Now, I have a pleasure to ask Professor Tanaka to join us for his lecture. Thank you so much.
Can you hear me?
Yes.
Ladies and gentlemen, my name is Shinji Tanaka. Thank you for joining this seminar. This is a 6th JNET virtual training seminar. I deeply appreciate Olympus for making this important opportunity. Also, thank you the invited faculty this time, Professor Matsuda, Professor Ebigubo, and Dr. Polchak, for your cooperation. The goal of this seminar is to standardize of JNET classification globally through keynote lecture for deep understanding of JNET classification and case studies effective for practical application in clinical practice. So let's start this seminar. At first, I will conduct my keynote lecture. と In this lecture, I will talk about how to take beautiful picture to use JNET classification precisely. JNET classification. This is a JNET, the Japan NBI expert team established in 2011. This team established JNET classification. This is JNET classification, consisted of 4 categories: type 1, type 2A, type 2B, type 3. A little complicated, but nearly very simple. Evaluative factor is vessel pattern and surface pattern. We have to both evaluate this indicator simultaneously. Type 1 is vessel invisible, surface pattern is regular. This is indicator for hyperplasia or SSL. Type 3, vessel pattern is disappear or scattering, and surface pattern is amorphous. This is indicator for deep submucosal invasive cancer. To distinguish type 2A and type 2B, we have to use magnifying observation. Type 2A, the difference between type 2A and type 2B. Type A indicate regular vessel pattern and regular surface pattern. Type 2B shows irregular vessel pattern and irregular surface pattern. Very simple if you understand like this. This classification is published in 2016. First author is Professor Yasushi Sano. I will talk about key points for precise use of JNET classification. We have to observe both vessel and surface pattern. The vessel is relatively easy to observe due to its dark color, but the surface structure cannot be observed correctly unless the focus is precisely adjusted. Therefore, in NBI magnified observation, it is essential to first focus completely for observing the surface. Due to the uneven surface of the region, it is important to focus your observation on the area of interest rather than vaguely expanding your observation. Also, observe from the front as much as possible. Furthermore, it is necessary to completely remove the mucus adhering to the region. In such cases, care must be taken to prevent bleeding from the region. What do you think of this picture? The focus is not complete. This is perfect focus picture. Do you feel this difference? Without removing adhesion mucus, evaluation under magnifying observation is not possible. The left image shows mucus adhesion and slight bleeding, making it difficult to make correct diagnosis. The right image is re-examination image taken at a later date. By this complete image, we can diagnose this region as JNET type 2B easily. In colonoscopy, change of body position is very useful. By changing body position, fluid in colon is moved away from the affected area. Further, we easily wash the region without pooling of fluid at the target region. When irrigating the region, don't apply the irrigation solution directly to the region. to avoid bleeding from the lesion. Instead, irrigate using flowing water directly from the periphery, like this. What do you think of this lesion? To correct diagnosis by NBI magnification, it is necessary to observe the lesion perpendicularly from the front. I'm sorry. When irrigate, I'm sorry. Lesion exhibiting irregular surface pattern or vessel pattern require observation at higher magnification. Type A is not enough to evaluate the area interest by JNET classification. Figure C, image C is enough high magnification to diagnose JNET classification. This region shows mild irregularity in both surface pattern and vessel pattern. So the diagnosis is JNET type 2B, indicating suspected cancer. Can you detect the lesion? Here. To correct diagnosis by NBI magnification, it is necessary to observe the lesion perpendicularly from the front. If the lesion cannot be viewed from the front, it is necessary to use non-traumatic tube to suppress the area in front of the lesion and position it for direct visualization like this. This 10 millimeter polyp with depressed area at the top of lesion. Depressed area is a little irregular. The depressed area is not visible from the front. I will demonstrate the actual procedure of using non-traumatic tube to visualize the area of interest from the front view via videos. We push the inner side of the lesion by non-traumatic tube like this. Top of the lesion, now we can observe perpendicularly like this. And adjust focus. We can diagnose correctly. I will show you countermeasures for when minor bleeding occurs. Spraying the 0.1% epinephrine dilution solution stops the blood oozing from the lesion, enabling NBI magnifying observation. I will show the importance of structural enhancement in NBI magnifying observation. As shown in the slide, image with various enhancement reveals that A8 is the best and essential in NBI magnification. So this is short summary. Key points in NBI magnification is correct system configuration, structure enhancement A8, color enhancement 3. And number 2 is most important. Always be mindful of the focused surface pattern on the area of interest and evaluate in conjunction with the vessel pattern. I will show bonus case. What do you think this region? 1 centimeter diameter flat elevated region. This is NBI high magnifying view. Surface pattern is disappeared, non-structure, and the vessel is scattering. So typical JNET type 3. So we suspect this lesion invaded deeply. EUS shows massive invasion close to muscle layer, and muscle layer is swelling. So we can diagnose this is not T1 cancer deeper than T2 cancer. This is surgically resected specimen. 2A plus 2C like advanced T2 carcinoma invaded, this region invaded into muscular muscle layer like this. Thank you so much.
Thank you, Professor Tanaka.
Okay, so please move to special lecture.
Yes, thank you. Now we'll share the pre-survey results with you. Chris, could you share the screen, please? So what is the region where your facility is located? So more than 50% of our doctors comes from EMEA region, but also we have participants that answer from APAC, so Asia and Pacific. We have participants from Americas, US, Canada, Latin America, and participants from Japan and other regions. Do you use magnifying colonoscopes in your daily practice? More than 60% of the doctors are using magnifying colonoscopes in their daily practice. Which endoscope do you usually use for colonoscopy? For example, manual zoom, dual focus with EZ, or others. And high-Q scopes and EDOF technology account for more than 60% of the total scopes used. Do you use the NICE classification in your daily practice? So 65.63% says yes. What are the clinical implications for your practice? So some of the answers was to define the best strategy for accessing the surface of polyps in order to properly remove them. More precise risk stratification and advanced therapeutic decision-making, especially for performing EMR and ESD or managing complex colorectal lesions. The clinical implication for my practice is to improve and consolidate my skills in using the JNET classification for accurate optical diagnosis during colonoscopy. It helps with diagnosis of polyps, and the use of NICE and JNET classifications in my daily practice helps improve a real-time optical diagnosis of colorectal lesions, supports appropriate decision-making for endoscopic resection versus surveillance, reduces unnecessary biopsies, and contributes to more accurate risk stratification and treatment planning for patients. Do you use the JNET classification in your daily practice? 70% of the doctors use JNET classification in their daily practices. Do you differentiate between adenoma and intramucosal carcinoma in your daily practice? 85.42% says yes. Which classification should be used in your country? 65% of the doctors believe that the JNET classification should be used in their country. and provide more details why you choose your previous answer. Some of the answers was the JNET offers a more refined and detailed optical histological diagnosis, more precise risk stratification, and advanced therapeutic decision-making, especially in practice performing EMR, ESD, and managing complex colorectal lesions. JNET classification provides more detailed and reliable optical diagnosis by correlating vessels and surface patterns with histology, allowing better differentiation between adenoma, intramucosal carcinoma, and deep submucosal invasion. It supports more accurate therapeutic decision-making, especially for selecting appropriate endoscopic resection techniques, and improves standardization of practice and training in daily clinical work. We use the JNET classification and Kudo classification daily practice, and the JNET is more accurate than NICE classification. Do you have any comments on the reason the JNET classification is not widely adopted in your country? Major 39 answered that the lack of training for JNET classification and use of zoom scopes. 35 answered limited number of physicians capable of ESD, and 27 participants difficulty in use of manual scopes for magnifying. Thank you so much.
Professor Tanaka, can I start?
Yes, please. Yes, please.
Okay.
Mr. Kanno, maybe introduce you.
Yeah, so now we have a pleasure to introduce Professor Matsuda. He will present how to use JNET classification in daily endoscopy practice.
Thank you, Mr. Kanno, for your kind introduction. Good afternoon and good evening, everyone. My name is Takahisa Matsuda from Toho University, Tokyo. It's great honor to be here today, and I would like to talk about how to use the JNET classification effectively in your daily endoscopic practice. This is my COI. I have received lectures fee from the companies listed here. When we encounter the highly colorectal regions, our most critical decision is whether to treat it endoscopically, such as EMR and ESD, or to refer the patient for surgery. Our goal is to avoid unnecessary surgery for intramucosal region while ensuring that deep invasive cancers are not undertreated. These are all early stage colorectal regions. How would you treat these regions? Endoscopic treatment or surgical resections? Actually, these 7 regions can be treated curatively by endoscopic removal. However, the other regions had a risk of lymph node metastasis. It means the cancer already embedded into some mucosal layer deeply, or lymphovascular involvement positive, or budding findings high grade. So, as you may know that the risk of lymph node metastasis in T1 SM cancer is approximately 10%. Risk factors include deep submucosal invasion, lymphovascular involvement, and poorly differentiated component and budding findings. However, as for us as endoscopists, we can only predict the depths of invasion in real time. We cannot see the lymphovascular invasion or budding grade through the endoscope. Therefore, precise endoscopic diagnosis of invasion depths is so vital. Historically, pit pattern diagnosis using magnifying chromoendoscopy has played an important role in estimating invasion depths. Maybe you know that Professor Shinye Kudo's pit pattern classification is the most widely recognized worldwide. I worked for many years in the endoscopic division at the National Cancer Center Hospital, and I have been using the simpler classification, which was proposed as a modification of the Kudo's classification by my mentor, Professor Takahiro Fuji. The invasive pattern is characterized by irregular or distorted pits within a clearly demarcated area. For example, the depressed area or such kind of reddened area is one of typical findings of demarcated area. I didn't find this demarcated area is a key to differentiating between invasive pattern and non-invasive pattern. Now, moving on to today's main topic, the JNET classification. Already, Professor Tanaka explained about the JNET classification from type 1 to type 4. I will explain again about this JNET classification. The JNET classification was developed by the Japan NBI expert team, and forms the core of today's discussion. It was established mainly by Professor Tanaka and Professor Sano and Professor Saito and their colleagues. As you may know, the JNET classification incorporates not only vessel pattern but also surface patterns, and categorize the region into 4 groups from type 1 to type 3. So why does JNET matters? Because endoscopic diagnosis should immediately guide treatment time and choose the appropriate treatment strategy on the spot. Today, I will focus on how we can use JNET practically in routine colonoscopy rather than discussing theory alone. JNET type 1 regions usually show invisible vessel or vessels with a caliber similar to normal mucosa. The surface pattern is regular with white or dark spots resembling normal mucosa. These features suggest hyperplus polyp or sessile serrated lesions, which are generally non-neoplastic. In JNET type 2A, both vessels and surface patterns are regular, with uniform caliber and organized structures such as tubular or papillary patterns. The most likely histology is low-grade intramucosal neoplasia, typically adenoma, making this type a classic indication for endoscopic treatment. Now, let's move on to after JNET type 2B. JNET type 2B shows irregular vessels and surface patterns, clearly different from type 2A. This category includes a wide spectrum from high-grade dysplasia, intramucosal neoplasia to submucosal deep invasive cancer, and therefore represents a gray zone. Additional evaluations such as pit pattern diagnosis is required to determine treatment strategy. Finally, let's discuss JNET type 3. In JNET type 3, the vascular and surface structures are severely disrupted with amorphous area and thick interrupted vessels. These findings strongly suggest deep submucosal invasive cancer. When diagnosed with high confidence, surgical resection with lymph node dissection is strongly recommended. This slide summarizes the treatment strategy based on the JNET classification focused on type 2B and type 3. For JNET type 2B, the pathological spectrum is wide, already mentioned before, ranging from high-grade intramucosal neoplasia to T1 deep invasive, submucosal invasive cancers. Therefore, type 2B alone is insufficient, and additional PIT pattern diagnosis is necessary to determine whether endoscopic resection or surgery is appropriate. In contrast, type JNET 3, when diagnosed with high confidence, type 3, such kind of regions should be recommended strongly surgical operation directly. However, the confidence level is low. I recommend you to perform the additional PIT pattern diagnosis. I will show the short video clip. The region was located in the left sigmoid junction. Under white light observation, you can see here the leaden area, very flat region can be observed here. And after switching to NBI, you can see the brownish area, the region and region margin clearly shown like this. And this region consists of depressed component, and the center of the region has a little bit elevated. And the surrounding area, depressed area, consists of type 2B, and the center of the region, you can see the thick vessels and the amorphous surface pattern. So therefore, doubted the type 3 in the center of the region, a little bit elevated component. So finally, this region we judged as type 3, and the surrounding area consists of type 2B, but worst part on the center of the elevated region should be judged as type 3. So we recommend the surgical operation directly. So as you can see here, you can observe the irregular distorted pit in this area. So we selected the surgical operation for this case. As you can see here, the region cancer already embedded into submucosal layer deeply, and the depth of invasion was more than 4,000 micro. And however, fortunately, no lymphovascular involvement and no risk of no lymph node metastasis in this case. Let me present another case. This case region was located in the lower rectum, and the size was 20 millimeter in size. The ordinary view, you can see the elevated sessile region. And after retroflexion, you can observe the depressed area in the center of the region. After the indigo carmine, you can see the depressed area like this. And we switch to the NBI. How about this? You can see the irregular vessel and the irregular surface pattern in this area should be judged as type JNET type 2B. So under such situation, we usually apply the crystal violet to observe the pit pattern in this area. In the center of the region, we can observe the unstained area. However, please be careful. In the left region, sometimes damaged mechanically, therefore should not easily judged as type 5N in this area, because the depressed margin consists of the 5I mild irregularity in this case. Therefore, finally, we judged as non-invasive pattern. So we performed the endoscopic treatment for this case. We performed ESD for this case. And the histopathological result was like this. Region cancer is limited in the intramucosal, so-called high-grade dysplasia. In Japan, the TIS, intramucosal carcinoma, like this. And of course, cut margin was negative. I would like to show you one more case. How do you think about this? This case was also located in the lower rectum RB. The size was 18 millimeter in size, macroscopic types, basically 2A, but the center of the region has a reddened area. Probably you can easily recognize this area. After switching to the NBI, in this surrounding area consists of JNET type 2A, very clear surface and vessel pattern. However, in this area consists of the irregular vessel and surface pattern. So it should be judged as type 2B or type 3. So however, the size is less than 2 centimeter in size. the region was located in the lower rectum. Therefore, we tried to perform the diagnostic EMR for this case. After the crystal violet, we can observe the irregular and very small tiny pit, so-called invasive pattern, so 5I, severe irregularity in this depressed area. On the other hand, the surrounding area consists of type 3L to type 4. So this image is RDI with crystal violet. And the lifting sign was non-lifting sign was negative. And fortunately, we removed the region by conventional EMR. However, the histopathology result was like this. Cancer embedded into some mucosal layer up to 2000 micro, and the muscularis mucosa is perfectly destroyed by the cancer invasion. So therefore, we measured the depth of invasion from the top of the region. So maximum size is 2000 micro invasion depth. And the lymphatic invasion was positive, but in grade was grade 1. However, this case was, we recommend additional surgical operation. And the lymph node metastasis was positive in this case. So finally, I would like to show you one more video clip. My region was located also lower rectum RB. The size was about 15 millimeter in size. After switching the NBI, you can easily observe the brownish colored area. The region margin is clearly shown. 2A plus 2C type. Center of the region has depressed area in here like this. And the NBI with magnification, how do you think about this? We can observe a type 2B in the center of the region. And mainly, we need to check precisely in this area, type 2B or type 3. But probably we judged as type 2B, but some doctors, experts explain maybe type 3 because we can observe sick vessels, are bit very controversial. But anyway, and after the injugocalamine, the depressed margin was more clearly shown like this. And pit pattern diagnosis. We can observe the unstained area partly. However, the depressed component consists of not so severe irregularity, type 5I, mild irregularity. So different diagnosis between JNET, NBI diagnosis, and chromoendoscopy. So we performed diagnostic EMR for this case. ESD was performed this case, and the cancer was limited intramucosal carcinoma, so intramucosal TIS region. And of course, cut margin was fortunately negative. So this is my last slide. Finally, I would like to present one take-home message. The first, the JNET classification is a practical tool that supports real-time diagnosis and treatment decisions in daily practice. Second, JNET type 2B is the most critical category because it covers a wide pathological spectrum, and many include deep submucosal invasive cancer. Therefore, in type 2B regions, careful additional evaluation is essential, pit pattern diagnosis or US, before selecting the treatment strategy. The third, accurate interpretation of both vessels and surface patterns, including the presence of demarcated area, is crucial to avoid misclassification. Finally, improving diagnostic accuracy requires continuous experience with well-characterized cases. Thank you very much for your kind attention.
Thank you, Professor Matsuda, for your presentation. Now, following the agenda, we have the clinical cases and discussions. For this session, we have Professor Tanaka as a moderator. We'll have 3 cases to be presented today. The case 1 will be conducted by Dr. Polishuk. The case 2 will be conducted by Professor Ibigibo, and the case 3 will be conducted by Professor Sano. Our discussant in the session will be Professor Matsuda.
Okay. Before case discussion, I have one question to Professor Matsuda. In my opinion, if we suspect a lesion deep SM invasive, we should confirm the concrete degree of invasion by EUS. What do you think of this concept?
Thank you very much. Very important point. In our university hospital and National Cancer Center hospital, we used to use the magnified pit pattern diagnosis. However, I understand the usefulness of US to measure the margin from the cut margin. If you tried, we perform the ESD, we should try to observe the margin of the cancer invasion to mass layer is very clinically very important. Therefore, Hiroshima University's doctor already published the paper, the importance of measuring the degree of the distance from the mass layer to cancer's deepest portion is very useful. Therefore, I agree with you. Not only pit pattern diagnosis, but also EUS is fundamentally very important as a preoperative treatment. Thank you.
Thank you so much. So let's move to case discussion. First case, Dr. Polchak, please show your slide.
Yeah, thank you. Thank you. Hello, dear colleagues. Thank you very much for the opportunity to present the case for the discussion session. I hope that it will be an interesting discussion and with my case. I want to present my disclosure. Yeah. And I want to present some short description about this case. Sorry. Okay, this was a follow-up colonoscopy after previous colonoscopy with polypectomy, free tubular adenoma with low-grade dysplasia, and patient was without any complaints. I used the colonoscope CF1200, and the site of lesion was ascending colon. The first endoscopic image is VLI mode. I'm using the Olympus CAT system and the artificial intelligence technology in this case. And when performing a colonoscopy, I prefer to examine the colon with TXI mode. And you can see slide with the TXI mode with the short video. So the lesion was a flat lesion, about 3 or maybe 4 millimeters in size. The next, so you can see some video with NBI mode, and of course endoscopic image with NBI and some zoom. I often use underwater view for additional analysis of endoscopic images.
Very beautiful.
And you can see some endoscopic picture with NBI. So I'd like to propose the first voting question to the participants about what is the type of JNET classification. Dear participants, please vote.
Please vote.
Okay.
Can we see some results? Okay. Thank you very much for what interesting results. And and let's analyze additional endoscopic image using indigo carmine and TXI mode.
Just a moment.
Yeah.
Here, let's discuss the diagnosis by faculty. Any comments from faculty?
Yes, I'm Dr. Sano. So
Please
I
show
wanna
NBI view.
yes,
NBI
please
Valentine view.
please back
Okay.
Back.
in NBI
I
video.
turn I turn to
Okay. Adjusted focus image.
Yeah.
Okay.
Okay.
Stop.
So
maybe I can show. Sorry, maybe I can show this picture.
Yeah.
Endoscopic.
Still image. Focus adjusted still image. Okay.
Yeah.
It's
okay?
Okay. Yes. So it's very interesting because most of the major answer was so JNET to be. And yeah, actually, the beginner endoscopist diagnose to be. This is a misunderstanding. So most of the tiny flat lesion like this, so size is 2 or 3 million size, mostly showing so depthless area. But mostly this tiny lesion covered some remaining normal epithelium. And at that area, sometimes showing so the bezels like this. Can I indicate? I'm sorry, I cannot indicate. But anyway, so later chroma endoscopy, maybe you can see much more clearly. But sometimes the bezels very clearly seen in this front time lesion, and so it's similar to sometimes so showing some irregularity, but we don't diagnose this is Janet 2. We usually diagnose as 2A. But anyway, so I want to later explain more exactly.
Yeah.
This
I
is-
will
thi-
late
this-
some another picture and we will discuss. Okay.
Yeah, this is Tanaka. At the center of the region, mucus is adhering. We have to consider this phenomenon. And anyway, vessel is a little irregular, but surface is very regular, except from mucus adhesion area. Also, please back to standard view. Previous view. Normal
Okay.
standard view. Okay. This red vessel is not natural. I feel this is artificial redness. What do you think, Professor Sano or Professor Masuda Sensei?
Sorry, I cannot understand what in this finding.
Redness is very
Okay, now. Okay, now I can see the redness. So in the white TXI mode.
Of course, this is TXI.
Yes, it's a TXI mode.
Standard view mode, no picture.
The first picture was, but it is not.
Okay, please. Okay.
yes, this reddish area is remaining normal epithelium covered on the this region.
Maybe
Yeah.
it's inflammation in this polyp. What do you think? These vessels. Inflammation.
Inflammation, yes.
Okay.
Dilated inflammative vessels. Yes, it's not so it's not similar to the real neoplastic neoplastic area vessels. You know,
Yeah.
so this is yes, vessels in the hyperplastic area.
This is a natural view, artificial view by contact, scope contact.
No, it's a natural view before scope contact. And I think inflammation can easily confuse about JNET in this case. Okay, may I?
Okay, please proceed.
Okay. And I return to additional endoscopic images using indigo carmine. And I like to propose the second voting question to the participants. And what is your diagnosis in this case? Dear participants, please vote. Is it tubular adenoma or SSL with dysplasia? Maybe it's cancer with SM1 invasion. Maybe it's advanced cancer.
Please vote. Please show us result.
Can you see the some results? Tubular adenoma. Okay, many thanks for interesting results. And let's analyze again and discuss about this case. I have a more picture with some short video with NBI. We're discussing about these vessels.
I think there's still mucus covering one part of the polyp.
Yeah, mucus, adhering mucus disturbs the correct diagnosis.
So I have a question. Is it vessel meshed capillary network regular or some irregular? What do you think? It's a regular or irregular?
Vessel?
Yeah.
Yeah, vessel is a little irregular, I think. However, tubular surface pattern is not so regular, but
Okay.
we cannot see precisely by adhering mucus.
Okay.
So
Thank you.
may I
Thank you
ask
for your comments.
may I ask a brief question to Professor Tanaka, Professor Sano, and Professor Matsuda? Very often in these very small polyps, we often have this slight depression, and we're a bit confused very often because the vessel pattern sometimes looks a little bit irregular, and we are confused.
Yeah.
Is it JNET 2B? Is it JNET 2A? We see this very often
yes,
in
yes,
small
yes.
polyps. What is
In
the
such
explanation? Why is
situation,
this?
you should evaluate the surface pattern. JNET classification is used by vessel pattern and/or surface pattern.
Okay, Porishiko sensei, please show me the indigo carmine dye still image.
Okay.
Yeah.
It's a next short video with
Yes. You know, okay. Please show the still image.
Okay. Yeah.
Yes, please. So in this view, you can see the depressed area between the reddish area. So in this tiny flat region, so depressed area, showing type 3 L pits, but reddish area is histologically it's a normal epithelium, covered with a normal epithelium, and also bezels, dilated reddish bezels, demarcated around each hyperplastic type 1 pit. It's a remaining the normal epithelium on the tiny tumorous area. We call this type lesion just two-way depression. And the surface is covered by remaining normal epithelium. And at that area, showing some dilated reddish vessels. So on the NBI view, we misdiagnose as a JNET 2B, but it's a not neoplastic vessels. It's just dilated vessels in the remaining normal epithelium. So that we don't confuse at that point,
Thank you so much, Sano Sensei.
Yes.
Explanation.
Thank you.
Key point is no destruction of epithelium.
Yes. And this remaining epithelium tumor is enlarged, and this area is replaced by the neoplastic epithelium, and the area will be gone and disappeared. Yes.
And one more key point. This specular type depressed area we never call 2C.
Yes.
2A
That's right.
depression.
Yes. That's right.
Specular depression is not 2C. Do you understand?
Yes.
Yeah. Thank you for your comments. It's very, very interesting and very useful.
Epithelium structure is very important to conduct precise diagnosis, procedural explanation.
Thank you again for interesting comments.
Time is limited. Please proceed.
Okay, thanks. Let's get back to analyze surface pattern in this case. For a more detail for the surface pattern. In this case, I used chromidoscopy with carmine and chromidoscopy with crystal violet. With these dyes, we can see the some surface pattern and pit pattern very, very clearly. Not only that, but with this zoom endoscope, we can see almost every pit individually. And you can see some endoscopic image. And I like to propose the third voting question to the participants. What is the type of pit pattern classification?
Let's hurry up. Please vote.
Okay. please show me the results of voting. Free L plus free S. Okay, interesting. And let's back to endoscopic images. So we clearly type free L and type free S in this polyp and the regular surface pattern. So in conclusion, my optical diagnosis in this case was JNET 2A. And so based on these signs in this case, the treatment decision was cold snare polypectomy. And you can see that in this short video. Then I routinely checked the resection margins, and you can see very clear resected margins. Then I can show, and you can see the some fixed resected specimen with pins. And so let's check pathology images. And I want to say very thanks my pathologist Hanna Lapsar from CSD Lab. And feel free to use the QR code to view the pathology slide. Finally, the lesion was diagnosed tubular adenoma with low-grade dysplasia and R0 resection margins.
Yeah,
That's all.
Thank you so much. Nice presentation. Key point of this region is vessel pattern is irregular, but surface pattern, epsilon pattern is regular. So we can diagnose JNET type 2A. Then adenoma. Your diagnosis is correct. Any question from faculty? Any comment? Okay. So time is limited. Let's go to next case. Please, Professor, thank you so much, Polchak.
Thank you.
Edigbo, please show your presentation.
Yes, thank you very much for having me, for inviting me. Can I see my slides? I have a simple case, as usual. Bruno, can I see the slides?
Yeah, 1 second. They are taking.
Okay, perfect. So it's also a small lesion. And okay, nice. You've heard the disclaimer. So it says, again, a small lesion, but this time I'm using an EZ 1500 colonoscope, also with the extended depth of field function. So I detected in the white light image a small lesion, smaller than 5 millimeters in size. It's very difficult to see here and here. And for these kind of lesions, very small polyps here, the white light image, you can hardly see the demarcation of the polyp in contrast to the surrounding mucosa. In such situations, it's helpful to switch not only to the TXI mode. In the TXI mode, even the demarcation to the surrounding mucosa is still not perfect. It's helpful to use indigo carmine spray to enhance the surrounding, to enhance the lesion from the surrounding mucosa. As you can see here, when you use indigo carmine spray, then you see the the border of the polyp very clearly in contrast to the surrounding mucosa. Here, again, with indigo carmine and TXI. So my first question is, what is your macroscopic type? Is it a type 2A, 2B, 2C, or 1S lesion? Please vote quickly. We have a very exciting third case from Professor Sano, so let's vote quickly. It's a flat lesion. It's almost completely flat. So it's definitely, and it's not depressed, so it's not 2C. It's either 2A or 2B. So it's, in my opinion, let's see the voting first. Yes, so it's something I say something between 2A and 2B. Definitely, there is a slight elevation there. So I think it's okay to say 2B because it's or 2A because there's still a slight elevation in the lesion. So let's continue. And then we move to the MBI, where we try to use the MBI for now the JNET classification. The image I brought along, I'm sorry, this is the best MBI image I was able to produce. What I can see here in this MBI image, first of all, I can see the lesion. There is a different color of the lesion in comparison to the surrounding mucosa. The vessels are not very clear to me, so almost invisible vessels. But the surface pattern is quite regular, is quite regular. And finally, I would like to ask you, what is your JNET diagnosis of this polyp? Is it JNET type 1? Is it JNET type 2A? Is it type 2B? Or is it type 3? So please vote. So the vessels, as I said, are almost invisible, or at least very faint. The pits are very regular, maybe even roundish, but not quite like the surrounding mucosa. And
Now in voting, never explain.
okay, yes. So in contrast to case number 1, I think we can see that there's a difference. And I agree with JNET type 1. So finally, we go to the next slide. And of course, this lesion is smaller than 5 millimeter. You can easily remove it with cold snare. It's a suspicion of non-neoplastic lesion. I thought it was a hyperplastic lesion, but it was in the right hemicolon. So maybe also sessile serrated lesion is possible. But in my opinion, it looked more like a hyperplastic, but I was not 100% sure. In any case, we sent for histopathology. So now, please, what is your diagnosis? Do you think it's a tubular adenoma with low-grade dysplasia or high-grade dysplasia? Do you think it's a sessile serrated lesion, or do you think it is a hyperplastic polyp? Please vote. We have a small lesion in the right hemicolon with a non-neoplastic pattern JNET type 1. So what is your diagnosis before I show you the histopathology?
Please vote. Please show
Voting is
result.
coming.
Oh.
Yes, so I know why these two answers were provided. If this lesion would have been in the sigmoid, I'm sure everybody would say hyperplastic polyp, but because it was in the right hemicolon, maybe some participants feel it could be a sessile serrated lesion. Finally, the histopathology, however, showed a hyperplastic polyp. The elongated crypts, maybe some cellular hyperplasia, but there was no serrated or L-formed L-shaped crypt. So the final histopathology diagnosis was hyperplastic polyp. Okay, thank you.
Any comment
Thank you.
from faculty?
May I ask the question?
Okay, please.
Professor Sana, you first.
Okay, so yeah, actually, this is histologically diagnosed as a hyperplastic polyp. But sorry, I learned pathology previously. In this pathological findings, in the surface showing so the hyperplastic so findings, so serrated findings, and showing goblet cells. But this is a bottom of the area, so goblet cell is not so many. So the histologically, I guess this region is diagnosed as a microvesicular hyperplastic part. You know, there is two hyperplastic part, microvesicular hyperplastic part and goblet cell rich hyperplastic part, you know, and a microvesicular hyperplastic part is a precursor region of the sessile serrate region. So that I guess so this is a tiny microvesicular hyperplastic part, but maybe enlarged, changed into the sessile serrate region.
Oh, so this is
know?
also the explanation why it is in the right hemicolon.
Yeah, I guess.
Ah,
So
thank
the
you.
so cloud surface like
Yes,
and
yes.
yeah, that's why the
Perfect.
reason. Yeah,
Thank you.
Sano
I
sensei?
think. Yes.
In this case, magnifying view is very weak magnification. So, but we can diagnose this is hyperplastic polyp. Is this indicative for endoscopic resection?
Sorry, this is not so big. Less than 5 million size. So that I think so. In Japan, we follow the region because size is small. But if the so enlarged if the region showing open type 2 pit or some suspects of the sessile serrate region more than 6 million size, or definite suspicious of the sessile serrate region, we try. But in this region, maybe I follow.
Usually in Japan, minute typical hyperplastic polyp is followed up.
Even in the right hemicolon.
Yeah, typical, definite hyperplastic polyp in minute size.
Yeah. Okay.
Maybe I have a question, if you allow me.
Okay.
If we find a similar 5 millimeters polyp in the rectum with JNET 1, what tactics would you recommend? Biopsy, live in situ, polypectomy, or another?
Professor Matsuda Sensei,
Yes. Now, recently, now in Japan, just leave it. Observation. If the region located in the lower rectum, the size is less than 5, just observation. We do not remove or biopsy. Yeah.
Okay.
Yes.
What about SSL in the rectum? You live in situ again? Sessile-serrated lesion in the rectum.
Of course, if we just sessile serrate region, we can try the removal by polypectomy. But if we judge that the hyperplastic nodule, just small, tiny hyperplastic nodule, just observation, just leave it. Yeah.
Okay, thank you. Thank you very much. And what about acetic acid in this case? Do you recommend use acetic acid in this polyp?
Sorry, pardon me, please. Sorry.
Do you recommend use acetic acid chromendoscopy in this polyp like this?
Yeah, some doctors try, but not common. Not so. I think not so useful to judge by when we judge by using JNET classification. Some doctors recommend to dye acetic acid to observe more clearly. However, some cases damage and easy bleeding. Therefore, I do not like to use the acetic acid at the moment. It's my opinion.
Okay. Thank you.
Anyway, key
Thank you very
point
much.
of this region. When we diagnose JNET type 1, we have to distinguish between typical hyperplasia and sessile serrated lesion, SSL. Surface structure is different. Thank you so much for your case.
Thank you.
So let's move to Sano Sensei's third case.
Thank you. So please prepare my slides. My case is a very unique configuration case.
They're
Okay.
preparing your slide.
Yes, please. The lesion is located in the lower rectum. Okay, so sorry. Oh, move forward. Just a moment. Move forward. Okay, this is describe here. Okay, the lesion was located in lower rectum, and the medical history was melanoma, and I used 1500 Ti dual focus scope, and this is a white line image, and I'm sorry. The lesion is very strange. So the features right side is protruded and left side is flat. And surrounding mucosa showing white spots like this. And this is retroflex view. We can clearly observe the flat area. And also the oral side also showing white spot. And this is NBI findings. And particularly focus on the protruding area. And protruding area is showing some irregular surface depressed area here, and but mostly so
Sano Sensei,
the
maybe you prepare a questionnaire, so never
hi,
explain answer.
okay, all right. This is protruding area. This is more closer findings, anal side or oral side view. Okay, so please for your diagnosis, JNET diagnosis, JNET 1 or 2A, 2B, 3. And so protruded area.
Please vote.
Is board. Please vote. Could you show me the answer? Okay. All right. So maybe 77% participants choose to be. Very nice. So I explain you. I'm sorry. My diagnosis. Okay. So my diagnosis is also the protruding area. So as you know, the surface is showing a lobular-like surface, and also the each focus on the surface structure, surface pattern, showing some irregular so running, and also the focus on the bezels, the surface structure right side also showing some irregular running, and bezels also some bezel thicker and some bezel is dot-like, and some bezel is thin, and a more closer view, anal side, the surface pattern showing so very irregular, but still remaining, not amorphous. Uh, all areas showing so irregular surface, and also the is variability of the so bezel density and the also thickness. So my
Sensei,
yes.
is there no mucus adhering mucus or was?
I guess this area you can see whitey area. I guess this area so-called was.
Not
Uh,
non-structure pattern, but adhering was.
yes, white opaque substance. It's reported by Professor Yao. It's oftenly so exist usually cancerous area.
To understand the was, it is very important to avoid misdiagnosis. Yeah.
Yes, they prove so this was is consist of the some kind of the lipid, lipid absorption. It's okay. So 松田先生 OK ですか ?To be
Yes, totally fully agree with your diagnosis.
okay. So we goes to so flat area. Okay. So this component so protruding, and the other side is a flat extension, and some close view. This is so flat area, and in the center, the flat area slightly elevated. And next, so this is a video. Please watch, enjoy. Okay, right side. This is a lateral flex observation. Okay, so flat area, mostly flat, but in the center, some elevation can be seen, right? Okay. So what is the diagnosis in this flat area? JNET type 1 to B, 2A to B3.
Please vote.
Please vote. Please vote. Oh. Show me the answer. Okay. So yes, 53 participants choose 2B and 30 percent 2A. Okay.
Sano Sensei,
Yes.
there is also was. Is it okay?
Just a moment. Was just a moment. I
Maybe doctor who diagnosed JNET type 3
okay. I think
misdiagnosed was.
I think in this case was area, yes. I think this
Yeah, very minute,
yes,
but
minute.
was exist.
Yes. I think this area and this area showing a minute was.
It's not amorphous area, yeah? I understand.
Yes, I explained my diagnosis. Flat area. So mostly the this part also and the right side part also still remaining. So the surface structure and the bezel finding is still keep the irregularity, but it's a border. But I diagnose this area is still remaining as a regularity and right side also. But in this area, showing some in the center elevation area, showing the bezels also just like so showing irregularity, very running. So caliber is running a very so randomly and showing irregularity, and also the this surface structure also not regular. So that this area I diagnose as a 2B. So yeah.
Maybe existence of was confuse the diagnosis.
I think some possibility due to the was. I show you the video once again. Sorry. So my diagnosis is this center of this area diagnosed as 2B, but the other is still 2A component. So 松田先生は your diagnosis.
Thank you very
How
much.
does
Very nice case. My diagnosis is JNET, basically type 2A, but some part already Sano Sensei mentioned consists of the type 2B. But I think the dominant is type 2A. However, many participants voted to the type 2B, is I understand. In some plots, some elevated area consists of the type 2 irregular bezels. Therefore, I understand the voting participant selection, but my diagnosis is mainly type 2A. In some small area consists of that should be judged as type 2B. So 2A dominant is my opinion.
Okay.
But Matsuda Sensei,
Yes.
there is cancer in adenoma. Cancer in adenoma is cancer, even if cancer area is very small, minute. So if there is a genotype 2B area, if small, this is genotype type 2B.
I understand your Professor Tanaka's comments. It's very important. The most worst diagnosis should be mentioned. So therefore, in some area, I judged as type 2B, and mostly type 2A. So under such situation, we should judge as type 2B. It's maybe Professor Tanaka's comment. Very important. I agree with your comments.
Okay. So I agree. So that I move forward. Okay. My diagnosis also to be. And to be with a 2A. And this is chroma endoscopy. And so this is a protruding area and flat area. And you can see the more flat pit, the pit pattern more clearly. All right. I want to ask you the morphology. What is a what is a gross diagnosis in this type region? So A, 2A or 1S or 2A with 2C or 1S with 2A. Please board. Hmm?
Please show result.
Yes. Hmm? Show results, please. Oh, okay. 1S to 76%. Oh, wonderful. Yes. Actually, this region is combined type, protruding 1S area and flat 2A area. So that this region diagnosed as 1S with 2A. Okay. Yes, wonderful. All right. This is not 2A. Mixed type. And also, I want to ask you, what is a diagnosis? Is depth or so histology? 1A is adenoma. B, TIS or SM1. C, SM deep invasion. Or D is far advanced cancer. Please board. Sorry. Show me the results. Oh, TIS1 SM1 is 65%, and SMD invasion is 25%. Okay. Good answers. Okay, so this is a pit pattern diagnosis after into common die. As you can see, the protruding area showing so irregular pits. I guess so. This is a Kudo sensor type 5I low grade, but in the flat area, the pit pattern still preserved, and also showing a smaller type 3S pits. And but this area, so this area only some strange findings. It's not so smooth pit, but it's not so typical type 5 pit, hyperplastic-like pit at this area. Then this area showing so some irregular pit pattern, so that this is a type 5I, but this area is still 3L or 3S, and then this area showing some hyperplastic-like change pit. But my diagnosis is also finally this region 1S 2A, and sorry, back. And depth of invasion is a TIS or SM1 slightly invasion. I also applied so crystal bio dye, and also the in proteolytic area. This is a pit. And the flat area. I'm sorry. This is a protruding area and flat area showing, yeah. So this is a slightly elevated area. I'm sorry. The pit enlarged, but still remaining. And the other showing some smaller pits. Here also the regular or small pits, 3L-like and small 3S-like pits can be seen. So my diagnosis is this pit is a Kudo sensor type 5I low grade, and so 3S and 3L, and in the flat area, this area showing some so enlarged hyperplastic change. This is so it's a difficult to diagnose before treatment. But anyway, my diagnosis is this moment. Can I go ahead? Tanaka sensei, okay.
Yes, okay.
Okay, I show you my diagnosis, final, sorry. Okay, so what is treatment? So finally, A is EMR, B is underwater piecemeal EMR, or unblock ESD, or D, research sending surgery. The size is around 2 centimeters, more than 2 centimeters. Wait, please show me. Oh, interesting. Mostly, oh, you like ESD. unblock ESD. Yeah, thank you.
Any-
Matsuda sensei,
Sensei,
yes,
anyway, en bloc endoscopic resection is essential. Is it okay?
yes,
Thank you.
yeah, support your 松田先生はどうですか？
Thank you very much. My selection is also ESD unblocked resection.
unblocked section.
In the protrude area, maybe consists of the cancer. Therefore, unblocked resection should be strongly recommended.
Okay.
So, yeah, I choose the ESD.
If endoscopist who can conduct complete en bloc EMR, EMR is okay.
Okay, so my diagnosis 1S2A lesion, 22 million size, located in the dictum and JNET classification type 2B, with a SO2A. And Kudo sensor type 5I with a mild irregularity on the protruding area. And my so clinical diagnosis is TIS or shallow SM invasion. So I performed so ESD and unblock clear, so the lesion dissected. And I show you final pathology. Sorry. Um, as you see, on in the so protruding area, so completely this is so showing well differentiated adenocarcinoma, tube 1. There is no findings of the adenomatous components. Mostly the surface area showing well differentiated adenocarcinoma. And sorry, but this area, so slightly, it's so the transition between the protruding area and so flat area, this area showing micro invasion. This is muscularis mucosa, and so small glands embedded to submucosa. Yeah. So the pathological diagnosis is T1A SM 130 micrometer, so margin free. And I show you flat area. So flat area showing so the my pathological so my mentors Professor Fujimori diagnosed as this area also so T1 a well differentiated adenocarcinoma, and also you can see the so flat elevation area in this component, this area. So this area is slide. Sorry, just back one slide. This area, sorry. This area, 菅さんちょっと OK. Sorry, yeah. This area showing a very interesting histology. The muscularis mucosa extend into the submucosa, but still preserve the muscularis mucosa in the submucosa. So that Professor Fujimori, this area diagnosed as a pseudo invasion, but still intramucosal components. But there is a big duct can be seen at this area, so that this is a cause the flat elevation finding can be seen in the endoscopically, and surface is slightly just a moment. This surface area slightly showing some lymph node lymphocyte infiltration and so dilated glands. So that the region why this area showing some hyperplastic change. But anyway, so the lesion is diagnosed. So submucosal invasive cancer. Invasive point is here, and this is pseudo invasion area. So diagnosis is 1S to a 12 2 million size, well differentiated adenocarcinoma SMT1A. Budding grade is 0 and lymph node and basal involvement negative.
Thank you
So
so much,
that's all.
Sano-sensei. Wonderful
Yes.
presentation. Professor Fujimori's pathologic diagnosis is low-grade adenocarcinoma, no adenomatous component.
Yes. So this.
But typical JNET type 2A.
Yeah.
But this pathological diagnosis is difficult, maybe among Japanese pathologists.
So
Sometimes different
maybe some pathologists diagnose high grade
high
dysplasia.
grade.
Yeah.
Sano-sensei,
Yes.
many thanks for a very, very interesting presentation, very interesting case. And do you inform your pathologist about the endoscopic diagnosis, especially JNET classification?
Yes.
All cases, yeah?
Yeah. All cases, yes. I sent the endoscopic findings also to the pathologist.
Thank you.
Yeah.
But in such situation, no bias in pathological diagnosis for pathologist.
Maybe Professor, my mentor, Professor Projimori, keep his.
Fujimori is okay, but
Yes.
it needs discussion. Thank you.
Professor
Thank
Sano,
you very much for showing us the very precise histopathological findings and endoscopic diagnosis. Very interesting case. Thank you very much.
Thank you.
Any comment from faculty?
just a question,
Ahmed?
Professor Sano, just a quick question. Can you just briefly explain what is the implication of this pseudo invasion that you showed on the histopathology slide? What is the implication? Is this associated with any other form of prognosis?
I guess so. In this finding, it's very strange. It's a rare findings, I think, because a very huge, hyperplastic glands can be seen in the center of the flat area, and as you see, my opinion. Sorry, I'm sorry. This sorry. What? Sorry. あれ終わっちゃいましたね。But anyway, the hyperplastic glands can be seen. It's not neoplastic histologically. It's very strange. But why does the such glands exist in the center of the flat area is it's very difficult to understand.
Yeah, Sano-sensei, thank you so much. Thank you so much for three doctors for nice case presentation. Time is limited, so I will pass to Mr. Kano.
Thank you, Professor Tanaka, and thank you all of you for the nice presentations. Following our agenda, now we have a presentation of our colleague Mia Dibek in introduction to EVIS-X1 and EDOF, EVIS-X1 Atlas and online training portal. Welcome, Mia.
Thank you very much, Bruno. I hope you all had already a very insightful time, and I will just briefly introduce myself. My name is Mia Dübeck. I'm a product manager for gastroenterology at Olympus Europe, so I'm responsible for Europe, Middle East, and Africa. So thank you very much for the opportunity to present our EVIS X1 system and our endoscopes today. You have the disclaimer first. Let me jump here. Now it's working. So I would like to start with our processor, the EVIS X1 processor, which provides you with a range of innovative features to accompany your daily work. So it supports you in every step of a procedure, in detection, in characterization, and in treatment. For example, we have our TXI. It is doing detection, very helpful. It's like our new white light. So it supports enhanced visibility of potential lesions. And also, for example, we have our new invented RDI technology. It's for the treatment part, where this technology enhance the visibility of deep blood vessels and bleeding sources. So it supports you in finding or identifying bleeding points, and this makes a hemostasis quicker and easier, and we want to support the doctors in this important situation, and also reduces stress in this part of a procedure. Going from the processor to our latest endoscopes, we have the EDOF technology. And I saw already that some of you are using the EDOF scopes already, so you will know what great picture it can give. So the technology behind it, we combine a picture, the near picture and the far picture. We combine it in one image, and have a total focused image with this. So you have a wider image, you have less blurring, and a higher magnification than our previous scopes with this new technique. And also the handling is a little bit easier, because we don't need to constantly switch between near mode and far mode and all of this. We can see this comparison very well in the next slide. So here you see our previous scopes above the red line. So we have the dual focus and the zoom from our previous scopes. And below the red line, we have our zoom scope and the EDOF scope. And you can see that the EDOF scope is covering all the technical enhancement and magnification that our previous scopes can do. So here you can see it very well. And but not only in our products like scopes and processors, we support your daily work. We also want to support you in training and in training material to get better every day. We are at your side, so always reach out to us if you have any questions regarding the products or regarding some technique requests. We are always there, and we will also provide some links so you can check also our materials, our learning materials, the JNET classification poster, for example, and we will send it in the chat, I guess, Bruno, later, so you can see this too. And with this already, thank you for your attention, and I give back to Bruno.
Thank you, Mia, for your presentation. Now I hand over to Professor Sano.
Okay, so to all the audience, thank you very much for participating this webinar. I guess we discussed a very good discussion in each cases. And thank you very much for good lessons, Professor Matsuda. It's very useful for the audience in the daily practice. So all the guys, in Japan, you don't believe, but we use magnifying endoscopy very oftenly, and we use detailed observation to distinguish between the non-neoplasia from the neoplasia and the normal from the intermucosal cancer or submucosal cancer daily. And the concept of the intramucosal epithelial carcinoma is not common in the West. And mostly, Western pathologists diagnose intramucosal lesion as high-grade dysplasia. But it is very important when deciding on the endoscopic treatment. So also diagnosis of the high-grade dysplasia is essential even in the region smaller than the 10 million size, which is often remove the cold pulpectomy. So we discussed the JNET classification leads to the accurate diagnosis and logical decision between EMR, ESD, or live in situ, or pulpectomy, standard pulpectomy, or piecemeal EMR. Anyway, so we always using a full category, live in situ, cold pulpectomy, or precise rejection using EMR or ESD, or sending surgery. These four action decision making is always we are facing to the each region in the daily practice. So that we need a four concept, JNET 1, 2A, 2B, 3. Four category is definitely necessary. So that's why we should use a JNET classification. And I think integration of the JNET classification into the European ESD guideline recently was a very welcome achievement. And in the future, treatment strategy for early colorectal cancer should be standardized worldwide, including United States as well, or South America as well. But this will require further discussion between Eastern country and Western experts, and also in Asia and Pacific physicians. So once again, thank you very much for your time today. We will close this seminar. Thank you very much.
Thank you, Professor Sano. And in the name of Olympus Europa, I want to say thank you for Professor Tanaka, Professor Sano, Professor Matsuda, Professor Ebigbo, and Dr. Polishuk for your incredible presentations today. I want to say thank you for all of our audience today. And we want to ask you to take a minute for answer our post-survey feedback. This is important for us also to understand what we can improve for our next events. After that, I just want to say thank you again, and we'll see you in the next event. Thank you so much.
Thank you.
time to participate in JNET virtual medical trainings. Thank you for your trust, and it is a great honor for me. This webinar is very useful for me again, and thanks to all faculty and organizers. Thank you to support. It is not safe in Ukraine now. We have been without lights and